Hello, and welcome to Talking About Tumors with Brian and Ryan. I'm Ryan Halstead.
And I'm Ryan Clin.
And today we're going to continue on with our pancreatic discussions, talking about localized pancreatic cancer. So as mentioned before, our goal here is to try to provide a general introduction to many of the disease sites that medical subspecialists will be encountering within the field of oncology. When we're talking about localized pancreatic cancer, this is a multidisciplinary disease with management including radiation, surgery, as well as chemotherapy. As we are not experts on either radiation or surgery, we will briefly overview some of these today, but maybe in the future we can have some people who know a bit more from that standpoint to weigh in on the different approaches and the emerging evidence to best provide care from different angles.
So as we mentioned, pancreatic cancer is a very difficult disease to treat, and even in the localized setting, the outcomes can be fairly poor, although there is a chance of cure. Only about 15 to 20% of disease is considered resectable at diagnosis. Surgery alone has a pretty low cure rate and is pretty poor at long-term outcomes. Many of these patients will recur either locally or distantly after surgery, which has led to investigation into adjuvant chemotherapy and neoadjuvant chemotherapy to help improve the outcomes for these patients.
Yeah, even for patients who are node negative at the time of surgery, where it looks like we resected everything, about 70% of these patients will have a recurrence in the first 5 years. Median overall survival is estimated 21 to 50 months. And those patients who are node positive at the time of resection, greater than 90% will recur. And median overall survival is estimated at 16 to 24 months. That being said, there is a portion of people who will never have disease recurrence, and our goal is to try to maximize those patients as well as improve upon our selection for the patients who go for surgery. And utilization of chemotherapy and radiation have been incorporated in many trials, which we'll briefly overview today, which have led to increasing the proportion of patients who are getting these long-term survival outcomes.
Yeah, very few patients are treated with surgery alone, given the poor long-term outcomes.
So briefly, before we move into the majority of today's talk, which will be about pancreatic adenocarcinomas, it's worth mentioning that there are other lesions that can show up as solitary lesions within the pancreas that we would need to differentiate between. The other possible malignant findings could be a lymphoma, a neuroendocrine tumor, and an intraductal pancreatic mucinous neoplasm. Due to the difference in management as well as outcomes with each of these lesions, it is important that if we find a solitary lesion that we get a biopsy to confirm the diagnosis. As lymphomas can be treated with a combination of chemotherapy and immune-based therapies alone, neuroendocrine tumors may or may not require resection or may require different staging evaluations using such as a PET dotatate scan. And intraductal pancreatic mucinous neoplasms may be able to be monitored without any intervention whatsoever. There's many details to the appearance of these lesions that can help separate one from the other. It is worth noting that lymphomas can often mimic adenocarcinomas, so just because the lesion is very suspicious, we don't necessarily want to go with an upfront Whipple surgery until we're certain what we're dealing with. But let's say we do in fact have an adenocarcinoma confirmed by biopsy. The next thing we would do is move on to staging.
So as with other cancers, the staging system that we use is the TNM system. However, in pancreatic cancer, it's kind of less important, and it's more important to group the tumors into 4 groups: resectable, borderline resectable, locally advanced unresectable, and metastatic disease. Briefly, the TNM system, the T is based on the size of the tumor. However, a T4 lesion is any size that invades the celiac axis or the superior mesenteric artery, and this is usually considered unresectable disease. We'll get into this more when we're talking about the difference between resectable, borderline resectable, and locally advanced disease. In terms of imaging, you really want to get a CT chest, abdomen, pelvis, although you want to make sure that you specify to the radiologist that you want a pancreas protocol and a CT triple phase scan, which does very thin slices and really gets a better look at the vasculature, which is important when we're deciding if the tumor is resectable or not. Alternatively, you can also get an MRCP, which some centers do.
I think when you say that the resectability being the most important thing, you mean that that's what's going to ultimately lead to how we manage the disease. The TNM, I think, does have the strongest prognostic impact, with node positive disease being the most likely factor for long-term survival.
Occasionally, a staging laparoscopy is also done, especially if the patient's considered high risk for metastasis, and just to make sure that you're not missing any peritoneal metastatic disease. Sometimes if surgery is being considered upfront, this can be done at the time of the surgery. And also if patients presenting with obstructive symptoms and elevated bilirubin, they may require the stent placement prior to any type of intervention.
Yeah, it may seem intuitive that if you see an obstructing lesion, you might as well just take it out prior to decompressing, but there is good evidence to support decompressing the liver, resolving hyperbilirubinemia, and then proceeding with a resection such as a Whipple. There's a greater post-operative recovery rate.
And of course, as we said, pancreatic cancer really is a multidisciplinary cancer site, so pretty much most cases will be discussed at tumor board to go over the treatment plan, especially when they're first diagnosed. So you want to make sure that you speak with your surgery colleagues and your radiation oncology colleagues, radiologists, to go over the resectability.
We've brought up the concept of multidisciplinary tumor boards quite a bit so far in our conversations. For people who are not yet practicing medical oncology, these are usually weekly meetings with local surgeons, radiation doctors, pathologists, radiologists, medical oncologists, as well as any other allied subspecialties such as gastroenterologists or pulmonary, who review individual cases, imaging, and path to try to determine the best approach. It's well established that these meetings improve quality of care, standardization of practice at a local center, as well as provide extra justification for management approach, especially when the best approach is uncertain.
Yeah, I highly recommend any fellows attending as many tumor boards as you can, especially now. I know at my center, given the COVID pandemic, they're still being done via Zoom, so pretty easy to just log on, but you get to see some interesting cases and review management, with experts that have been doing this for years. So it's definitely an educational experience if you can make it to the tumor boards.
Yeah, I really find them interesting, especially the different approach that surgeons versus radiation doctors versus oncologists have towards the disease. The one limitation with these, which is always something to be cognizant of, is ultimately the recommendations will be based upon what the standards of local center are. And as we get into these areas where there's not great evidence to differentiate between either chemotherapy alone or chemotherapy with radiation or neoadjuvant versus adjuvant, a lot of times the tumor board will end up standardizing within what that local center does, and you go to another tumor board, at the next cancer center over, and they do things completely different. So although these are good to standardize protocols, they also sometimes lead to a siloed approach. It's important to keep in mind that what you may see done time and time again at your local center may be just due to what the local consensus is and may not necessarily be the standard across the country. So as we move on, we'll try to discuss our best interpretations of the literature, but we're mindful that our biases are also based upon the tumor centers, the tumor board discussions that we've been present at. So we've been discussing this concept of resectability, which is somewhat unique to pancreatic cancer. I don't know of other tumor sites that use this to the same extent for management. But ultimately, these are vaguely defined terms, and they're based upon prior surgical trials where they retrospectively looked back at patients who had a Whipple or pancreatectomy, then looked at the radiology findings and found what findings were most likely to lead to a R0 resection versus an R1 resection versus an R2 resection, keeping in mind that R0 is no residual disease left behind, R1 is microscopic disease left behind, and R2 being gross residual disease at the time of operation left behind. Obviously, the chance of removing the entirety of the tumor is going to increase our chance of cure.
So about 15 to 20% of patients will be considered resectable at diagnosis. Now, the criteria for being considered resectable is that you have no tumor contact with major arteries, such as the superior mesenteric artery, the celiac artery, and the celiac axis, and the common hepatic artery. In terms of the veins, you want to have less than 180-degree involvement of the portal vein and to the superior mesenteric vein. And you don't want to have any venous irregularities or thromboses. Basically, surgeons now sometimes are able to reconstruct the venous architecture. So if there's any kind of vein irregularity that they think that they wouldn't be able to do a venous reconstruction, that would be considered non-resectable.
Yeah, these tumors that are kind of abutting the veins are causing some occlusion of the SMV are now what we would call borderline resectable, which is to say that they can possibly be removed, but the chances of having an R0 resection is less so.
And the surgeries that are done, we've all heard of the Whipple procedure, very long surgery. I'm sure people remember from the surgical rotation in medical school. So tumors that are in the head of the pancreas will have a Whipple procedure, which is also called a pancreatico-duodenectomy. So they remove the pancreatic head mass as well as a portion of the duodenum. Tumors that are in the body of the pancreas or in the tail of the pancreas will have a distal pancreatectomy. And these patients often require a splenectomy as well, depending on if the tumor is invading into the spleen.
And although the details of surgery, as you mentioned, are kind of beyond the scope of our conversations here, there is some data showing that doing a radical retroperitoneal lymph node dissection, which is common in some other diseases, has not shown to improve outcomes in pancreatic cancer. And briefly, those tumors that are more than 180 degrees of the SMV or include the SMV without an opportunity to reconstruct would be fall into the definition of locally advanced. I think one thing that is worth keeping in mind is you'll see these patients with either borderline or locally advanced. Even though the odds of having success here are less, we want to give these patients the benefit of the doubt. Our goal is for cure, and if there's an opportunity to do surgery and there's a chance that we may remove everything, it's certainly worth having that conversation. And but of course, always keeping in mind the risks and benefits to be discussed with the patient. And this certainly is a morbid surgery. We won't go into too much detail about the short-term morbidity of it, but I think as a medical oncologist, it's worth being aware of the long-term complications, because many of these people will come to us afterwards, either in the state of recurrence or for adjuvant systemic therapy, and being able to manage and be aware of the complications of not having a pancreas will help with optimizing care. Ultimately, these patients will probably be having co-management with either a gastroenterologist or a palliative care team. But some of the complications to keep in mind are steroiduria, which can present itself as abdominal cramping, especially with fatty diet. And to get around this, we can attempt to use things such as Clin, which is pancreatolipase. If you're at a center where the medical oncologists are usually prescribing this, ballpark treatment of this is using 30,000 units with a meal, half of that with a snack, with the hope of providing those digestive enzymes at the time of meals. And then we kind of titrate up or down as needed to maximize symptomatic control. Patients might have a lot of gastritis or GERD, and using H2 or PPI can be helpful. A lot of diarrhea, which is helpful with Imodium, and huge risk of pain, especially if there's local recurrence occurring. And using judiciously using opiates can help out as well. Keep in mind, we're also removing the source of islet cells, so you may have to be monitoring sugars for diabetes as well.
So in patients that initially are considered resectable and have an upfront surgery, as we said, the outcomes still can be pretty poor, which led to the development of adjuvant and the investigation of adjuvant chemotherapy. These patients can take a while to recover since it is a major surgery. We try to get patients within 8 weeks of surgery to start adjuvant chemotherapy, as was done in many of the major trials looking at this.
So being mindful that it took a long time before we were able to achieve great response rates using multi-agent chemotherapy. The earliest studies looking at these perioperative regimens were using a combination of chemotherapy and radiation. It wasn't understood that we could obtain a symptomatic response from radiation directed to the pancreas. So in 1985, one of the first trials looking at this combined radiation along with 5-FU chemotherapy. And this was a small trial that did show a doubled median overall survival of 20 versus 11 months. Because of this study, became a lot of interest in using chemotherapy and radiation for all patients with resected pancreatic cancers. Although, due to the small size of this trial, it was thought that the extended benefit was likely spurious. And in fact, a follow-up European trial, looking also at a combination of chemotherapy and radiation after surgery, was unable to find any benefit at all. Skirting over a lot of the details of these individual trials, but short of it is that each trial we're going to talk about is using a different radiation regimen, often different chemotherapy regimens. And this is a common issue with combined modality trials, where in order to have a center sign on to these trials, they're going to require a surgeon, a radiation oncologist, and a medical oncologist at a single site to agree to randomize their patient population. And if one of those three specialties does not believe in the trial or does not believe in the radiation regimen being used. They just won't enroll, or they'll only select certain patients. And many of these trials were closed early due to poor accrual or had to be adapted afterwards. So we're going to be talking about a lot of different approaches, a lot of different regimens. Unfortunately, a lot of these were not compared to one another. And even to today, we're not certain whether or not what's the best combination of chemotherapy and radiation, or whether radiation is necessary whatsoever. Although there was an attempt to try to look at a 2x2 fashion between chemotherapy and radiation. I think Ryan can go into more detail on that.
Yes, this was a pretty ambitious trial. It was a European trial. It's called the SPAC-01, and there were 289 patients, and they randomized patients to either adjuvant chemotherapy, chemo-RT, and then chemotherapy afterwards for observation. There was kind of a fear that this would accrue very poorly, so
they did a protocol now. Initially, they were randomizing it 2x2, which meant that patients were randomized to one of those 4 arms with direct comparisons looking at chemo versus nothing, chemoradiation versus nothing, and then chemoradiation versus chemotherapy, as well as focusing on whether or not sequential or concurrent was better. However, due to the poor accrual, they did amend and allowed individual providers to decide whether or not they're going to enroll people on chemotherapy versus nothing or chemoradiation versus nothing. So unfortunately, that 2x2 is not going to be as relevant when we get to the outcome study.
So one of the findings of this trial is that regardless of patients got radiation, if they got chemotherapy, the outcomes were better. So the 5-year overall survival was 21% in any of the arms that had chemotherapy versus 8% if they did not receive chemotherapy, so if they were on the observation arm. There was a trend actually towards worse survival in the chemo-RT arm. The overall survival was 10% in the arms that had radiation versus 20% in the chemotherapy alone arms. Although the study was not really powered to compare chemo versus chemo-RT, so can't really say much about that, and there was, as we said, poor accrual.
This was a really good trial that at least justified that there is a role for adjuvant therapy. However, it did further call into question the role of radiation. This being another European trial was another one of the reasons that in general in Europe, adjuvant radiation is not a commonly reached for modality, and many of their trials do not include that as part of the treatment regimens. And I think it's worth mentioning that to date, there has not been a well-controlled, randomized controlled trial showing significantly, in the phase 3 setting, showing significantly improved outcomes with the addition of radiation to chemotherapy. However, as patients have a high rate of local recurrence, there's still an interest to try to treat this way. Trials continue to initiate looking at this question.
I realized we never actually said what the chemotherapy was in this trial. It was a 5-FU based chemotherapy regimen, so just single agent 5-FU. So as we see in the metastatic setting, gemcitabine can be an active agent in pancreatic cancer. So this led to people looking at adjuvant gemcitabine after resection. So this was studied in the Conroy T study. It was about 350 patients who had surgical resection, and they randomized them to 6 months of adjuvant gemcitabine versus observation. And this was another positive study suggesting benefit of adjuvant chemotherapy. 5-year overall survival of 20.7% versus 10.4%. And this was actually regardless of whether or not they achieved an R0 resection. So this led to gemcitabine being used commonly adjuvantly after surgery.
As multi-agent chemotherapy became the standard of care in the metastatic setting, there have been a number of trials comparing multi-agent chemotherapy versus gemcitabine alone in patients with either an R0 or R1 resection. This has been looked at with both gemcitabine, capecitabine, gemcitabine and nab-paclitaxel, and modified FOLFIRINOX. And all these multi-agent regimens have shown superior to gemcitabine alone. However, there has been no good comparisons of these multi-agent regimens versus a chemo-RT regimen. So there'll still be an asterisk here as we go into the outcomes of these studies.
Yeah, probably the most impressive of these studies is the PRODIGE 24 study, which looked at 6 months of adjuvant FOLFIRINOX versus gemcitabine alone. It showed an overall survival of 54 months in the FOLFIRINOX arm versus 35 months in the gemcitabine arm. Now we have to take into account that these were probably pretty fit patients because, as we know, FOLFIRINOX is pretty toxic, and we really only select this for patients that are very fit. So that could be why the overall survival was better in this trial as opposed to other trials. But to date, this is probably the longest overall survival we've seen in pancreatic cancer study.
60% of patients had R0 resection, and this was using 6 months of systemic therapy.
So this really led to FOLFIRINOX being kind of the treatment of choice for adjuvant treatment for very fit patients. If you have someone with a kind of poor performance status, you can consider gemcitabine alone. For somebody with a more borderline, fairly fit patient, you can consider gemcitabine Abraxane or capecitabine with gemcitabine, because there's trial data to support all of these approaches. So as we saw in the SPECL-1 study, the role of adjuvant radiation is still very controversial. Right now there's no definitive evidence. So most patients, if they get surgery up front, it's really not standard of care to incorporate adjuvant radiation. The ASCO guidelines do say that you can consider it if you have someone who's node positive or have positive margins, but those are really kind of specialized cases.
So the standard of care in most locations now is moving towards a neoadjuvant approach, whether that be chemotherapy or chemotherapy and radiation. There's going to be limited studies that we'll be able to talk about here to justify this, but I think most experts agree, looking at how this disease behaves and how well it responds to chemotherapy, and the fact that we're going to be using adjuvant systemic therapy for all resected tumors regardless, that there's good justification for giving these agents up front. These assumptions will mirror what we've talked about previously in the gastroesophageal arena, as well as what we'll talk about later in the rectal cancer arena. But ultimately, given the fact that most pancreatic cancers are going to recur early, often within the first year, there's a general sense that these tumors are often stage 4 at the time of diagnosis. A lot of times after a Whipple, there's a delay to being able to administer systemic therapy. Not every patient is able to receive this. Given that there's effective multi-agent regimens, there is a chance that these agents could potentially address micrometastatic disease that's present at the time of resection. Furthermore, the higher the chance that we can get an R0 resection, the thought is the better chance of having long-term outcomes, further justifying the role of neoadjuvant therapy. Also, given the fact that more and more patients with borderline resectable disease are being resected, or those with locally advanced disease are being considered for resection, there's also a thought that potentially giving neoadjuvant therapy could downstage the tumor and increase the chances of these R0 resections. Although the randomized controlled evidence to support this is a bit limited. I think the best study we have available is the PREOPANC trial, right?
Yeah, so the PREOPANC trial just recently published an update, which now, originally it was actually a negative trial, and now it's actually positive a few years out. So this was a phase 3 trial looking at about 250 patients. Half were resectable and half were borderline resectable. And this study randomized patients to either surgery up front with adjuvant gemcitabine versus gemcitabine with radiation, and then surgery with 4 months of adjuvant gemcitabine. Now, one thing to note, as we just said, adjuvant gemcitabine is no longer really considered the standard. However, when the study started, it was. So we have to, think about that when we're interpreting the study. That is this still relevant in the era of, adjuvant FOLFIRINOX or adjuvant gemcitabine Abraxane? But the study did show that there was an increase of rate of a R0 resection in the preoperative chemo-RT group, 71 versus 40%. Now, initially there was no difference in overall survival. However, the recent update that was just published now shows an increased rate of 5-year overall survival, 20.5% versus 6.5%. And when they looked at, this was a pre-planned subgroup analysis, so when they looked at patients with resectable disease versus borderline resectable disease, there was a benefit to neoadjuvant treatment in both of these groups.
Yeah, so even though the median survival is somewhat similar, the fact that there's an improved number of absolute percentage of people alive at 5 years raises the thought that perhaps we're managing to capture a few more patients and converting them into one of these curative settings.
Yeah, the difference in overall survival, I forgot to mention, which is a good point. The median OS was 15.7 months in the chemo-RT group versus 14.3 months.
Another follow-up study with similar focus as this one was a meta-analysis, and this was looking at various neoadjuvant versus adjuvant regimens. However, worth noting, not any of these trials had a FOLFIRINOX arm in it. Also seemed to justify better overall survival using a neoadjuvant approach with a hazard ratio of 0.66.
Yeah, another thing was in terms of neoadjuvant radiation, the PreOpanc study doesn't really help us answer this question if the radiation is helpful.
I think given the significant benefit using modified FOLFIRINOX and the lack of evidence showing either FOLFIRINOX followed by radiation or FOLFIRINOX with radiation, that the standard of care really right now should be patients who are fit, receiving a neoadjuvant course of FOLFIRINOX, often for up to 6 months prior to surgery, and those who are not fit enough for FOLFIRINOX to get something such as gemcitabine and nab-paclitaxel, or maybe gemcitabine capecitabine, although I'm sure many of you may see a combination of chemotherapy regimen, chemotherapy and radiation being given in the neoadjuvant setting. But I'm not aware of any great data to support this over these other agents, and we'll be interested to see how that evolves as more trials published or as the general expert consensus evolves.
Yeah, I've seen the same at my center too. Adjuvant FOLFIRINOX if they're very fit, or gemcitabine Abraxane.
One thing I didn't mention is about one of the other justifications for neoadjuvant therapy is, as within the metastatic setting, there are some pancreatic cancers that are just refractory to even first-line chemotherapy, and these are the bad apples of the pancreatic cancer world. They're the ones who are going to behave poorly no matter what we do. And by giving 6 months of chemotherapy, where those patients who would have a rapid recurrence or lack of response to adjuvant chemotherapy in the first place are going to be progressing over that period of time. And this could serve as a way of identifying those patients who would not have benefited from a Whipple prior to going through this highly morbid, aggressive surgery.
Yeah, that's a good point. I've seen a lot of patients who progress right after surgery, and it's pretty devastating because they have a lot of side effects from the surgery. It seems like it may not have helped anyway, but there was no way to know that at the time of doing the surgery.
Yeah, this is known as the trial of time. It sounds somewhat counterintuitive sometimes, and it's a hard thing to discuss with patients, especially if there's nothing else visible at the time of the initial diagnosis. Why don't we just remove all that we can see? So I think it's important to kind of be aware of this justification and be ready to discuss that with your patients should they inquire why we aren't resecting and giving chemotherapy up front.
Now, in terms of locally advanced unresectable disease, this is now almost being treated like borderline resectable. We're treating now with neoadjuvant treatment, and there's always a role for at least rediscussing with the surgeon, if you see improvement on imaging, if there's a chance that this could eventually be resectable at some point. So for locally advanced disease, we really start with systemic therapy alone. So as we've said, FOLFIRINOX, gemcitabine, nab-paclitaxel, gemcitabine alone, maybe for less fit patients. There was one study looking at the addition of radiation to this, which is the LAP-07 trial, which randomized patients. Everybody started with 4 months of gemcitabine alone, and if there was no progressions, half of them got randomized to chemotherapy with radiation, and this was a capecitabine-based radiation versus just continuing with gemcitabine. This study didn't show any overall survival difference with the addition of radiation. There was a very small PFS, progression-free survival difference, but no overall survival difference. So really systemic treatment alone without radiation is considered standard currently for locally advanced disease.
Yeah, another trial worth mentioning is the Conroy 007 trial. This had a somewhat complicated design where they took patients, they randomized them to FOLFIRINOX versus gemcitabine for 3 months, and then those patients were then subsequently randomized to either continue with that chemotherapy arm or chemotherapy with radiation for another 3 months. This trial did show that patients who were randomized to the addition of radiation arm did have a higher R0 rate of resection, but this did not translate into improvements in overall survival or progression-free survival. This is a small study, given the fact that there was multiple arms involved with 402 patients. And I'm not certain if it really convinces us one way or the other whether or not giving chemotherapy alone or chemotherapy plus radiation is the best approach in these patients. And I think we would have to defer to our local centers and opinions. My personal opinion is in line with Ryan's, which is to use a chemotherapy alone regimen up front. And of course, keep in mind enrolling patients in the clinical trials can help answer some of these questions.
So talking about surveillance, so patients that end up getting surgery, what do we do to monitor to see if the disease is coming back? There's really no consensus on this, and if you talk to different people, they do different things, and European centers tend to do different things than American centers. The majority of patients will relapse within the first 1 to 2 years. So currently, at least American guidelines are to do clinic visits every 3 to 4 months. with blood work, looking at liver and kidney tests, do a CA 19.9, especially if it was elevated at diagnosis, and to do CAT scans, imaging every 3 months for the first 2 years. And then after 2 years, you can space this out to 6 months. There's really no data to guide us on this, and there's not really much evidence that kind of early detection of these recurrences that may be asymptomatic improves the patient's overall outcome.
I mean, if they recur within a year after getting chemotherapy and radiation, it's just I don't know what you really do at that point. But.
Yeah.
All right, so we hope this was a helpful view from 1,000 feet of what is a very complicated and evolving field. We expect there's going to be ongoing changes to the approach of pancreatic cancer in this arena and much evidence over the subsequent years. Unfortunately, there's no new breakthroughs in the most recent ASCO meeting, but hope that we can continue to improve the long-term outcomes and develop a better basis of evidence for our management and patients with this disease.
Yeah, definitely a controversial area. So as Ryan said, enrolling your patients in clinical trials that are looking at this is definitely helpful.
And to survey your local experts to see how they approach this, because we're hearing people who've delved a lot more deeper in the literature to see how they wish to approach this disease.
So on that note, I think that's it. Hope you guys enjoyed it. And again, please give us feedback via email or Twitter. We'd love to hear from you. Take care. Stay cool. Take that out. I'm sorry. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.